Cardio-renal syndrome, there are interactions between heart disease and kidney disease. And these interactions are bidirectional, which means acute or chronic dysfunction of one of these organs can lead to acute or chronic dysfunction in the other organ. These definition or cardio-renal syndrome is defined as it is pathophysiological disorder, and there is a lack of clarity with regard to the diagnosis and management. There are 5 types of cardio-renal syndrome, and the classification is according to whether it is acute or chronic process, and also depending on which dysfunction of which organ lead to the dysfunction of the other organ. Like in type 1 and 2, there is a kidney or heart disease leading to kidney disease. So in type 1, acute heart failure lead to acute kidney injury. For example, like in cardiogenic shock. All of us, we know that cardiogenic shock can lead to acute kidney injury. So that's type 1. Type 2, it's chronic heart failure that leads to chronic kidney disease. Type 3 and 4, it's the other way. So it's kidney disease that lead to heart disease. In type 3, there is acute process, acute kidney injury, like for example, acute tubular necrosis is an example, that lead to volume overload and then heart failure. So acute kidney injury lead to heart failure, acute heart failure. Type 4 is chronic kidney disease that lead to chronic heart failure, and that is common in practice. So there is left ventricular hypertrophy and cardiomyopathy. In type 5, it's different. Type 5, systemic disease that lead to the dysfunction of both organs, heart and kidney. Best example is in diabetes, where we have kidney disease and heart disease. Also, other examples are amyloidosis, sepsis, liver cirrhosis, so a lot of examples. Now, I'd like to present Mr. X, who is a 77-year-old gentleman presented to a hospital with shortness of breathing, increasing shortness of breathing, increasing leg edema, and chest heaviness. That's on the background of type 2 diabetes, diagnosed 11 years ago, with multiple complications, including diabetic nephropathy with baseline serum creatinine of 240 micromole per liter and eGFR of 22 ml per minute. Also, history of bypass surgery, hypertension, heart failure with ejection fraction of 40%, GRD, and gout. Medications, he's on furosemide, 80 milligrams a day, maximum dose of perindopril and amlodipine, also on aspirin, metoprolol, pantoprazole, linagliptin, which is Tradjenta, and allopurinol. He is a current smoker, and in emergency, when he was presented to emergency, he was dyspneic, hypertensive, tachycardic with a rate of 120 per minute. He put on 4 kilos, so he's 974 kilograms, which is 4 kilos above his weight. There are signs suggestive of heart failure, including high JVP, crackles on examination of the chest, leg edema. There's also systolic ejection murmur on heart examination. Investigations, ECG confirmed AF with rapid ventricular response. Chest X-ray, there was edema, moderate interstitial edema. Serum creatinine was 284. BNP was quite elevated, close to 3,000. And troponin just slightly elevated. Urine test showed no blood. Okay, so question 1, it comes to our mind, what is the precipitating cause of his cardiac symptoms? It's obvious that Mr. X developed decompensated heart failure. And the precipitating cause of heart failure in this situation is most likely related to new onset atrial fibrillation. Other possible causes include new MI, non-compliance with fluid restrictions, or non-compliance with diuretics, non-compliance with salt restrictions, And then infections can cause this condition, like pneumonia. So we need to search on all these possibilities, but AF is on the top. Now, he received a baseline management of heart failure in emergency, plus amiodarone for AF, boluses of IV furosemide, total of 120 milligrams initially in emergency. And he had a good response to Lasix. He urinates 800 mils in first 2 to 3 hours. And then he was transferred to CCU. In CCU, his urine output started to decrease, okay, to a rate of 20 to 30 mil per hour. Transthoracic echocardiogram in CCU showed reduction in EGF and ejection fraction into 20%, is low. In emergency, in CCU, his amlodipine and perindoprol and metoprolol all ceased. Because of his serum creatinine here, it was increased into a high level, so more than 300, which indicates acute kidney injury on the background of chronic kidney disease. So acute kidney injury plus oliguria, management here was dopamine infusion and commencement of furosemide infusion with a dose of 10 milligram per hour. He responded well to this treatment and he started to urinate well again. Next day, he started to improve. His potassium improved. His creatinine started to decrease. He lost 3 kilos in first 2 days, which means 3 liters of fluid. And then next day, he continued to improve. Serum creatinine improved to close to baseline. Chest X-ray improved. And then the day 5 improved further, and now switched back to oral Lasix. IV Lasix stopped, dopamine stopped, and then he was commenced on restarted on small dose of perindoprol, 2.5 milligrams, and small dose of bisoprolol, cautiously, 2.5 milligrams. And then the day after, he was discharged home with a plan to see his general practitioner in 3-4 days, and back to a cardiologist in 2 weeks. Advices to restrict fluid into 1.5 liters a day with salt restriction, and to weigh himself every morning. Now, another question 2. Would we consider anticoagulants? And if so, what type of anticoagulants should be used? So according to Chad's VASC score, the score was 6, which is high, and it indicates 9.8% risk of stroke or systemic embolization per year. And with this score, he definitely will need anticoagulant. Now, next, the second part of the question, type of anticoagulant. This condition is non-valvular atrial fibrillation, and there's an indication for NUAC rather than warfarin in these situations. We depend on creatinine clearance rather than EGFR in deciding the type and the dose of NUAC. Okay, so I will leave the discussion of anticoagulants to my colleague, Dr. Ali Fayyad. The second part of presentation tonight, we'll talk in details about anticoagulants. But just to mention something, this patient, Mr. X, his creatinine clearance was 24 mil per minute, which is low. Now, question 3, he presented to his GP in 4 days post-discharge. So what do you expect treatment by his family doctor? His family doctor assessed his fluid status and he repeated the biochemistry or renal function test and reviewed his medications and of course his weight as well compared with the weight on discharge. And consider these 3 treatments. He is already on furosemide, he's on RAS blockade. RAS blockade is renin-angiotensin-aldosterone system blockade, which is perindoprol. And he is on bisoprolol, which is beta blocker. In terms of furosemide, it depends on fluids and fluid status and his renal function, decide whether a decision must come to whether increase the dose or keep the dose the same or even decrease or increase. Now, RAS blockade, perindopril, he's on small dose. We may increase it depending on blood pressure and depending on renal function, and of course, on serum potassium. There is the agent Entresto, which is a relatively new medication used in patients with heart failure with reduced ejection fraction. It's widely used now, and I will talk about it later, but this usually will leave the cardiologist better. Beta blockers, I would wait because this medication has negative inotropic effect, especially a patient who just recovered from heart failure, decompensated heart failure. So probably we'll wait another 2 weeks and then increase the dose. But it is important to increase the dose. And I'll come to discuss in details later after pathophysiology to mention why it's important to increase beta blockers or RAS blockade. In terms of spironolactone, which is aldosterone antagonist, we may add this medication. It has a favorable benefit or effect on the prognosis when it is added to RAS blockade. And then a question about SGLT2 inhibitor, which is an example like Jardiance or empagliflozin, or Forxiga, dapagliflozin or ertagliflozin. It's well-known agents. It's widely used in patients with cardiac events, and it has positive prognostic value and reduced mortality and rehospitalization. However, in Mr. X, his eGFR is only 22. These medications should be used in patients with eGFR more than 45. So it is not an option. While other top four options still may consider. Now, chronic kidney disease in Australia, it's quite common. So about 10% of Australian population have some form of chronic kidney disease in their life. The problem is only 10% of those people are aware of CKD, while the majority are unaware simply because it is asymptomatic. It is harmful because chronic kidney disease is an independent risk factor for having cardiac events. And the most common cause of death in patients with chronic kidney disease is cardiac events, heart attacks. I will skip this slide. Now, this is slide, pathophysiology, it's important. So we have in this diagram, you see left-sided heart failure and right-sided heart failure. So in left-sided heart failure, there is inability of the heart to generate forward flow, pump failure. So there is decreased cardiac output, which will lead to activation in neurohumoral mechanism. And that is the core of the problem in cardio-renal syndrome. In neurohumoral mechanism activation, like renin-angiotensin-aldosterone system, sympathetic nervous system, and vasopressin. This will lead to a reabsorption of vasoconstriction, reabsorption of salt like sodium, and reabsorption of water in renal tubules, which will cause more problem because we'll have more congestion by reabsorption of water and salt and sodium. Also, there will be oligouria because of course, because of retention of sodium and water. So that's from left side. From right-sided heart failure lead to increased central venous pressure, which will be reflected on renal venous pressure. So increased renal venous pressure will antagonize arterial pressure and will cause more problem. So these together will contribute to the process of kidney failure. Plus, natriuretic peptides, bradykinin, and prostaglandins all work together, make cardio-renal syndrome worse. Chronically, there will be intrinsic renal disease. That's a long term. I would like to mention to you this slide, important slide. All of us, we know this is the glomerulus with the efferent arteriole. So blood comes to for filtration here, and then efferent arterioles that outward flow. Now, in this process, when I mentioned the neurohumoral mechanism, activation of vasoconstrictor agent, which is angiotensin 2, strong vasoconstrictor agent, this will lead to vasoconstriction here in the different arterioles here, which will lead to increased pressure in the glomerulus. I'd like to mention here an important point, because this process in acute condition is important, because by increasing the pressure inside the glomerulus, we'll have good filtration. If we antagonize this process by giving like perindoprel or IRBs, there will be vasodilatation here in the efferent arteriole, which will lead to decreased pressure. In hospital admission, we don't want to give perindoprel or other agents, because we want pressure here high, not to decrease the pressure. And this is important, especially in my general practitioners colleagues, because in hospital, it's a bit confusing. We stop perindoprel, but on discharge, we have to restart. Why we restart? Because in chronically, these agents are important because in chronic, as a long-term, decreasing pressure here in the glomerulus is important to avoid injury and to reduce the incidence of glomerular hyperfiltration, glomerulosclerosis, and glomerular damage. That's in chronic process. But in hospital, we stop it because we need the pressure high temporarily. That's why we have to reintroduce this medication, but gradually, small dose, and then increase the dose after that. So we need to consider and not to forget to reintroduce these agents. So I talk about now pathophysiology. These are the here. Now, treatment strategies in cardio-renal syndrome. Having heart failure and renal failure together carries a poor prognostic outcome. So it's bad. And those patients are so it needs close monitoring by their general practitioner, by the nephrologist and cardiologist. We expect a slight elevation of serum creatinine when we give these agents, like perindoprel, or ACE inhibitor, IRBs. But we should accept slight elevation in this in serum creatinine. Slight deterioration in renal function. Don't stop it, because it has a long-term benefit. Other point is, I mentioned that in the previous slide, don't forget to reintroduce ACE inhibitor IRBs, also later beta blockers. If the patient is not discharged without it, then we should consider GP general consider to restart this medication, even if there is slight decline in renal function. Now, these are I will talk about these agents again, but in more details. That's furosemide, RAS blockade, beta blockers, and spironolactone. First, about furosemide diuretics. It's one of the decongestive therapies. The most important diuretic used in heart failure is furosemide. It's loop diuretic. Just to refresh your memory, it works here in the thick ascending loop of Henle. So by water excretion and natriuresis, which is losing of sodium with urine. So both water and sodium loss. And that is the process why it is decongestant. And treatment is empirical, which means it's different from patient to other. The dose of Lasix or furosemide depends on patient condition and volume status and degree of heart failure, of course. Trials show that diuretics or Lasix has no long-term benefits. It's only decongestive therapy. So it doesn't improve survival in the future. Another way of decongestive therapy, if furosemide fail, we have ultrafiltration. Of course, there are other loop diuretics, but the most common one used is furosemide. Ultrafiltration in the hospital setting is another decongestive therapy, but again, it has no positive prognostic value. ACE inhibitor and ARBs, these are, as mentioned, it has definitely, by several trials, it has long-term benefits and decrease mortality and improve and decrease rehospitalization post-discharge, and that's well known. Now, number two, naprolysin renin-angiotensin inhibitors, which is Entresto. It's widely used now in patients with heart failure with the reduced ejection fraction. It's found better than ACE inhibitor and ARBs in this regard. But when to decide it's better? But again, it depends. Using this medication, we should consider these medications after assessment of renal function, serum potassium, and blood pressure. It may reduce the blood pressure because it's part of it is sacubitril, which is vasodilator, plus valsartan, which is, as you know, it is IRBs. So this combination is proved to be very effective. Mineralocorticoid receptor antagonist and most widely used is spironolactone. It works because it antagonizes the aldosterone. And there is a condition called aldosterone escape phenomenon when we use ACE inhibitor and ARBs. So by using spironolactone, it will have an additive effect. So by using it with other agents, it's proved to be of benefits in different trials. Beta blockers, very important in all stages of CKD from stage 1 to 5. And the types of beta blockers, according to trials, prolonged acting or long-acting metoprolol, not the short-acting, nebivolol and bisoprolol. These, according to medical trials, it's of benefits in long-term, has favorable long-term effect. This table will summarize the value of these agents. We see the tick on these agents that have strongly indicated and has long-term benefit. That is ACE inhibitors, spironolactone, beta blockers, while cross is on medication that is useful but doesn't have any long-term prognostic value. So diuretics, one of them, digoxin, for example, doesn't improve survival. Okay, so that is this table. Now, I will skip this slide and this slide as well. That's because of the sake of the time. I mean, I won't go in details. Now, conclusion. CKD and heart failure are common. They often coexist. And when we have two organ failure, the prognosis is not good. I mean, it has unfavorable prognosis. CKD is a strong risk factor for coronary heart disease. And it's the strong independent risk factor for coronary heart disease. And the most common cause of death in patients with CKD is cardiac events rather than other causes of death in CKD. More than 40% of patients with heart failure have CKD. Okay? And presence of the two organs failure, like CKD with heart failure, make it worse, of course. Because pharmacotherapy is complex and is difficult to manage, and patients carry unfavorable prognosis, they need close monitoring by a general practitioner, by a cardiologist and nephrologist. They need to be in contact. And always consider changing the dose or increasing the dose, depending on fluid status and other factors, renal function and renal function as well. Now, it is recommended to keep patient on RAS blockade or on beta blockers and possibly mineralocorticoid receptor antagonists. As mentioned, these are mineralocorticoid, which is spironolactone, which has a effect. And as mentioned, naprolysin, renin-angiotensin blockers like Entresto is used now widely in patients with reduced ejection fraction. I'll skip NOAC. I'll leave it to Dr. Arif Fayyab. Renal function should be considered when choosing the type of anticoagulant. It's an important factor. And as I mentioned, creatinine clearance calculation rather than eGFR is used in deciding whether to go with the NOAC and what dose of NOAC used. Okay, thanks. And that is the end of my presentation. I'm happy to answer any of your questions.
Thank you very much. Thank you very much, Dr. Mohammed. A very great presentation. I will, we open the panel for questions that I'll asking you myself. You mentioned that that there is so 5 types of those cardio-renal syndromes. Which one is more? Which one is the most common? And is there any way to prevent the development of cardio-renal syndrome, especially in an inpatient setting when everything is going all right and all of a sudden the kidney fails? Is there any general recommendation? How can we avoid the development of cardio-renal syndrome?
Okay, sorry, I will go. Yeah, so there are 5 types as mentioned. In practice, type 4, which is a chronic kidney disease that lead to heart disease, is the most practical, most common in practice. Of course, the other acute conditions is more in hospital setting. To prevent these agents, this process, there are medications as mentioned. First, that's treatment. Mentioned the 4 lines of treatment. Prevention is volume assessment, ACE inhibitor IRBs, or naproxen or sacubitril. This has long-term benefit and it may prevent the process. And careful assessment of fluid status, which will, help to reduce the incidence of rehospitalization and, of course, improve survival. As I mentioned, there are agents in the table that I showed to you. There are certain medications that we used, and I re-emphasize the importance of these agents in order to prevent this process, or to stop the process or minimize the effect of this process. As mentioned, RAS blockade, beta blockers, possible spironolactone. These are the agents that every patient should be on it when it is appropriate.
Sure, thank you. There's a question from Dr. Al-Fayyad. How would you calculate the dose of oral Lasix after cessation of IV Lasix? Is there any common way?
There's actually, I mentioned that it is empirical and depending on patient condition. Just to mention that IV Lasix is oral furosemide is equal to the dose of IV multiplied by 2. So when we give, for example, IV furosemide 40 milligrams, it's equivalent to 80 milligrams. So if patient is stabilized on 80 milligrams, maybe we start with 160 milligrams. It might be equivalent when patient stabilized, and then assess patient. As mentioned, pharmacotherapy is complex, and it needs ongoing follow-up by the general practitioner, other physicians. But that is the process. As I mentioned, it's equal to double process, and it depends. It is empirical treatment. I mentioned that in one of the slides. It varies from patient to patient. Yeah.
Sure. Dr. Ahmed Rubai asks, what is your NOAC choice in renal impairment, and how do you dose adjust?
Yeah. Okay. So if I go to my slides. Okay, sorry. I prefer to go to this calculation. First of all, this is, I didn't mention that just for the sake of time. So this is the way to calculate creatinine clearance. Patient age, patient weight in kilograms, sex, and serum creatinine. And then we get creatinine clearance. That's important. And then there is a cutoff for this creatinine clearance now. For Xarelto is the lowest now. We can go down to 15 ml per minute. We can give Xarelto safely. If creatinine clearance is below 15, it is unsafe. Eliquis is another one. The cutoff is 25 ml per minute. And Pradaxa or dabigatran, it's 30. So it's the safest of these 3 is 15 in patient with renal failure to go down. Now, Pradaxa is used twice a day, or Eliquis twice a day, Xarelto once a day. So just to compare between them. For me, I mean, safest is Xarelto now. A patient have, like Mr. X in our example, like his EGFR, his creatinine clearance was only 24, I think. So using Eliquis is unsafe. So we go to Xarelto. So that is, I hope that answered your question. So that is how it's according to whether it is safe or unsafe. Just to add a small thing, it is found that Eliquis, there is a few papers using Eliquis is safe in patient on dialysis, but not in advanced kidney disease. So pre-dialysis patient, for example, having EGFR of 15, EGFR of 12, we don't use these agents because it's unsafe. But if patients start on dialysis, yes, we can, because it can be cleared. And there is, and just to mention also that the difference why we go to, I mean, in Pradaxa, it's not cleared well. Sorry, it's it depends on the clearance by the kidney. And this medication is different from 1 to 1. That's why we now we go down to 15 in Xarelto. Yeah. I hope this will answer the question.
Yeah, thank you. As the last question from Dr. Leila about spironolactone and with the risk of hyperkalemia in reduced creatinine clearance. How would you comment on that?
Sorry, I will repeat the question. So she's asking about spironolactone.
Yeah, in patient, if the use of spironolactone is associated with higher risk of hyperkalemia, especially if the creatinine clearance is less than 25.
Yeah, so that's why we need to assess his patient potassium, serum potassium. If serum potassium is normal or above upper normal, then it is safe. If it is not, then we can't use it. Actually, if there is a risk of persistent hyperkalemia, then we probably will stop it. There are certain medications now used in patients who have persistent hyperkalemia, and if we have to give ACE inhibitor, IRBs, or Entresto, or even spironolactone, one of them is now the most available is Resonium, if we have to. And there are other agents still not used in Australia. But that's if we have, but in practice, if patients have persistent hyperkalemia, it is too risky to continue on spironolactone.
Thank you very, very much, Dr. Mohammed. That was a very good review, and I think we're doing very well in time. It's 8:43. I would introduce now our colleague, Dr. Ali Fayyad, with a quick summary about the most update about atrial fibrillations and anticoagulants. Dr. Ali Fayyad graduated from Al-Mustansiriya University, Iraq, came here, finished a PhD with the University of Melbourne, then became a fellow of the Royal Australasian College of Physicians, then became an interventional cardiologist, now working at Austin Health Melbourne. He is currently a director at Heartscope Victoria and a private cardiologist at Moonee Pond Specialist Center. Thank you very much, Dr. Ali, for sharing your experience with us and your update. Please go ahead.
Thank you very much for the introduction, and welcome everyone for this lovely night. It's the first webinar for IAMA. And as Dr. Mohammed said, I'm a cardiologist from Melbourne. Here we go. So the update on AF and anticoagulation, and the reason why I've chosen this topic, and I changed a little bit away from Dr. Mohammed al-Mukhtar Cardio-renal, because there's a new guideline in the European Society of Cardiology just came up this year addressing few points in management of atrial fibrillation. As we all know, atrial fibrillation in simple way, it's a chaotic rhythm in the top chambers of the heart and the atria, with some of the leads conduct through the AV node into the ventricle and causes the irregularity in the heartbeats. Now, it is quite important to know and understand the epidemiology of atrial fibrillation, or the prevalence of atrial fibrillation. This is a very nice illustration of the prevalence of atrial fibrillation around the globe. The red is more than 900 per 100,000, and the green is less than 600 per 100,000 population. And clearly you see in the Middle East, Africa, and part of Asia, they probably have a very small number of atrial fibrillation. Whether you blame the poor recording, medical record, or it's a reality, we don't know. But this is basically what the World Health Organization agreed for. That's probably, there's a lot of reason behind it, and maybe the main risk factors that can lead to atrial fibrillation can be blamed here. And genetics and ethnicity probably the cause. But also aging population. As we all know, Africa and Middle East and part of Asia, they are not an aging population. And we know that the older we get, the more likely to have atrial fibrillation. And male gender is more likely to have atrial fibrillation. Well, these are the main risks, we believe, but there are a number of risk factors that can lead to atrial fibrillation. And I can't really go through every one of those risk factors, and happy to share this slide with you at some stage if you want to. Now, why bothered? 15 years ago, a study published says, well, rate control and rhythm control are the same. Why bothered? You're managing patient with atrial fibrillation and try restore rhythm. Why bothered? Just keep it the rate control and should be fine. Well, that's wrong. And over the last 15 years, we learned a lot about this. We learned that atrial fibrillation can lead to even death, can lead to increased risk of stroke, LV dysfunction, dilated mitral and tricuspid annulus, lead to dilatation of the top chambers, the atria, increase in the pulmonary artery pressure. Patients get shortness of breath. He will end up with mitral valve replacement and dilated ventricle, and etc., 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 and even likely to depression and a lot of other complications. So rhythm control is crucial in terms of managing atrial fibrillation, if you're able to, of course. If you can't, you don't have any other options and you go for the rate control. But we should aim for rhythm control. Now, the link between atrial fibrillation and aging, as I said, the older we get, the more likely we develop atrial fibrillation. And the physiology is clear. The ventricle becomes stiff, the end diastolic pressure increases, pushes the pressure in the atria, lead to atrial fibrillation. And that's how we get atrial fibrillation when we have pulmonary embolization. That's how we get atrial fibrillation if you go for bypass surgery. That's 25% risk of atrial fibrillation post-bypass. That's how we get atrial fibrillation when we get older and we have a stiff heart and diastolic dysfunction. So the older we get, the more likely to develop atrial fibrillation. And this graph is clearly showing that if we continue as an aging population, continue to grow old, the risk of atrial fibrillation increases. Again, I'll go back again and say, well, let it be. Well, no, we should actually think about it twice. There is an over 1/3 of patients with ischemic stroke have atrial fibrillation. That's every stroke patient. 1/3 of them, they have atrial fibrillation and their stroke are more severe. In other stroke sufferers, atrial fibrillation is like the likely cause, but they didn't know about it beforehand. So at time of presentation with stroke, they now know this patient had atrial fibrillation. So it's a preventable problem that we just probably go blind eye. We don't think about it much. Patients with atrial fibrillation are 5 times more likely to suffer a stroke than those without atrial fibrillation. So it's a risk. And on top of all that, the cost on the population is huge. In Australia, we spend about 1.25 billion per year to manage patients with atrial fibrillation. Why? That's why. Look at this graph. How many health professionals involved in managing patients with atrial fibrillation. It's not just the cardiologist, it's the AF nurse, it's the general practitioner, it's the pharmacist, it's the families, the carer. And if you go out of this ring, Daniel Andrew called it the ring of steel around Melbourne. We've been in quarantine for the last 100 days. I agree with Daniel Andrew, but anyway, if you go with that, there's a large number of health professionals involved in managing patients with atrial fibrillation. So it's cost that we're probably able to save if we identify patients at risk and manage them correctly. Now, yes, I understand that the death rate, as this graph shows, decreased since 1990. Since we have been managing patients quite well, we dropped the death rate down. But if you look at the graph here and you look at the red and blue, the blue for men and the red is for women, the death rate for those who are above 75 is still very high. So how are we going to manage that? I think we need to understand atrial fibrillation quite well. Early identification of atrial fibrillation is crucial. How do we identify them? We can't really give a monitor for every patient, but with the availability of technology now, probably we can. We just need to educate people. When the GPs, the general practitioners, and every health professionals need to check blood pressure, check heart rate every time they see patient coming. Now, the phone, just 1 second, sorry. So we need to double check and check again and again to identify patient at risk, patients with atrial fibrillation, as I said, by using different gadgets, different technology. Now, atrial fibrillation, there are two major types, valvular and non-valvular. To separate between these two groups, the non-valvular atrial fibrillation, it refers to atrial fibrillation that occurs in the absence of mechanical prosthetic heart valve and the absence of moderate to severe mitral stenosis. When we start talking about anticoagulation and we say NOAC is indicated for those patients who have no mechanical valve and no valvular disease, what we mean by the valvular disease is moderate to severe mitral stenosis. If they have aortic stenosis, aortic regurgitation, other type of valvular disease, still NOAC is indicated. So we don't necessarily need to use warfarin. Now, as I mentioned before, treatment still need to restore rhythm. So rhythm control is better than rate control. This is a very busy graph. I don't want you to go through everything, but to start with, when you identify patients with atrial fibrillation, you need to think about the underlying cause. Now, blood pressure need to be treated. Heart failure need to be treated, dyslipidemia and diabetes. So that the use of ACE inhibitor, the A2RB, the statin therapy, all these risk factors need to bring those under control. Now, you can divide your patient into three major groups: those with no underlying or major structural heart disease, those with preserved ejection fraction, and those with reduced ejection fraction. And if you look at the therapy for all these three groups, you can see in common, amiodarone would be probably the main drug used mainly in the preserved heart failure and reduced heart failure. It's the best antiarrhythmic drug can be used. Unfortunately, lots of side effects on the thyroid, liver, kidneys, but still, it's the main drug we use to control atrial fibrillation. Now, if medical therapy failed, or sometimes even you go in young patient and you think probably we can't wait for the medical therapy to work, you can go for catheter ablation. Catheter ablation now has become the main procedure for most of atrial fibrillation patients if they are suitable. So you can see catheter ablation in every group if patient is suitable. Sotalol it's become like a second favor. Amiodarone and flecainide are the best drug you can use, and you always can combine them with beta blockers to control rate and control rhythm as well. You need to keep in mind, flecainide we cannot use in patient with heart failure, and even all with patient with heart failure with a preserved ejection fraction, probably need to avoid flecainide as much as you can and use amiodarone instead. Now, in the aging population, I'm just moving this slide a little bit further now and going to the chronic kidney disease and aging population. We know the older we get, the bleeding risk increases, and also the death rate and the stroke also increases in aging population. So when we use anticoagulation in this group of patients, we need to be careful as which anticoagulant we use and how we're going to monitor them. Moving into the anticoagulation, as we touched a little bit on the antiarrhythmic drugs. Now, the other arm of a treatment for atrial fibrillation is the anticoagulation to reduce risk of stroke. Before the introduction of NOAC, we didn't have more than warfarin. And warfarin, as you all know, it's a vitamin K inhibitor and work mainly on the intrinsic pathway. NOACs become available, and the three agents we have here in Australia is the rivaroxaban, apixaban, and the dabigatran. Dabigatran is an antithrombin, and the rivaroxaban and apixaban are factor Xa inhibitor. The question that always I get asked, do we start on anticoagulation? At what age we start on anticoagulation, and why? And I think the tipping point here is what is the risk of stroke in this patient? If the risk is 1% and above, the answer is yes, you start on anticoagulation. Why? Because the risk of bleeding using NOAC is less than 1%. So if your risk of bleeding less than 1% and risk of stroke is more than 1%, so the answer is yes, you have to use anticoagulation. And that's actually a very nice illustration of that. Even like you are 35 years of age, if you have heart failure, you should start on NOAC. In your 50s, whether you have diabetes or high blood pressure, you have to start on NOAC because you get CHA2DS2-VASc score of 1 or 2. And here, the risk of stroke is more than 1. In your 55 and you had a heart attack or a stroke, you definitely need to be on NOAC. Above age of 60, yes, you need to be on NOAC. So the tipping point, if your risk of stroke higher than 1 or 0.9, you need to start on NOAC. And you calculate your risk by using the CHA2DS2-VASc score. Simple. Now, when you use NOAC, you need to think about using the NOAC on-label dose, not the off-label dose. So on-label dose, if you don't have renal failure, if your age is less than 80 or 85, if your risk of bleeding is low, if your body weight above 60 kilogram, you use a full dose. If you use a low dose or use adjusted dose, you will end up with a stroke. So don't go blind eye. You need to think about, is this patient qualified for adjusted dose? If the answer is no, you go for the full dose, full stop. As simple as that. And for the interest of time, I'll try to move faster here. Now, the interaction, as any other drug, we need to think about the interaction. And the main one that can interact with other drugs, the drug that we use is a dabigatran. It interacts with the verapamil and amiodarone. I just highlighted this, given that the amiodarone we use quite common in patients with atrial fibrillation. That's the only point probably I want you to draw your attention to. Rivaroxaban and apixaban has no major interaction with the main drugs we use, but there are some others, so you can check interaction anytime. So just to summarize what I said, and I will go into different slides afterwards, I just want you to show you an example of a patient. This is an 81, so she's above 80. Weight of 51, she's below 60 kilogram. BMI is low as 19, and she's got some degree of renal failure as a creatinine clearance of 44. So this is almost like no-brainer. What dose of NOAC you need to give them? It's an adjusted dose. So if you go with the Eliquis, you give 2.5 milligram twice daily. If you go with the Xarelto, you go 15 milligram once daily. So weight is important, age is important, and creatinine clearance, as Dr. Mohammed Al-Mukhtar showed how we calculate creatinine clearance. Someone would ask, okay, what about the fall risk? This patient is frail. This patient is 80. This patient having lots of falls. What is the risk of bleeding here? As we all know, there's a Hasbled a calculator, so you can calculate the risk of bleeding. So that can give you an indication as what is the bleeding risk. But the frailty, and I think I'll leave that sort of discussion to geriatricians. If we have a geriatrician in the group, we can ask this question. But in the guideline in 2018 said, if you give a patient warfarin, this patient would have to fall 295 times in order for the risk of a subdural hematoma to outweigh the benefit of anticoagulation. Well, this is not a study. The answer is yes, that's clear. But it's not a study, it's not a randomized study. This is basically as an analytical model. And those who don't know what Markov analytical model, it's a connection, it's a statistical model, and you come up with these numbers. But it's clearly that even you are on warfarin, you still have to fall 295 times in order to have the risk of subdural hematoma outweigh the benefit of the anticoagulation. So the answer is yes, you give those patients anticoagulation and deal with the frailty. If patient has a high risk of fall, you basically just, you give them some sort of exercises, balance exercise, dancing claps or whatever, but try to improve the quality of life by giving them anticoagulation and stop them from having stroke. It's quite crucial to assess those patients quite well. And by the end of the day, the European Society of Cardiology suggested that group meeting, family meeting is quite important to identify patient at risk and explain to them what's the pros and cons. Now, what happens if you give a patient a reduced dose of NOAC, as I mentioned, off-label NOAC? It shows that the Danish study clearly showing if you give patient a reduced dose of NOAC with no indication, so this is patient with normal renal function, and you give them a reduced dose of NOAC, the risk of stroke increases by almost 5 times. That's mainly for the apixaban group. The dabigatran group and the rivaroxaban group, it did not show that significant increase in risk. And the reason being, we don't have a dabigatran of 75 milligram twice daily. It's available in America and Europe, but it's not available here in Australia. What we have available is a 110, so it's not the half dose. And the rivaroxaban, when we drop the dose, we drop it from 20 to 15. It has a longer half-life, and it's a higher, probably it's a lower trough, but it's a higher peak. And that's why probably the risk is almost equivalent. But when you give the Eliquis, you halve the dose, so the risk of stroke increases significantly. So do not use off-label dose unless you have renal impairment. So this is the same study I talked about, the Danish nationwide cohort, and it says that the Xarelto, that's for patient who is over 80 and they have a reduced renal function. And we can use a reduced dose or adjusted dose Xarelto. It's beneficial over warfarin. So it favors Xarelto over warfarin in treating patients with renal impairment, while the dabigatran and apixaban is equivalent. With the bleeding risk, it looks the same. So in the Danish study, in patients with renal impairment, it favors the use of Xarelto over other NOAC and favors the use of Xarelto over warfarin without increase in the bleeding risk, which is an important point. Now, as Mohammed showed, that there's a new indication for Xarelto, that the 15 milligram dose can be used even with the creatinine clearance down to 15. So anticoagulation NOAC is effective, equivalent to warfarin in patients with renal impairment and atrial fibrillation, and it is safe. there is no increased bleeding risk compared to warfarin in patients with renal impairment. Effective and safe. This is a slide just to show that patients with renal impairment and atrial fibrillation basically share similar risk factors. The higher the CHA2DS2-VASc score, the more likely to have more renal impairment. And it's not because of the CHA2DS2-VASc score, it's just because the score we use to calculate risk of stroke and atrial fibrillation, the risk factors there are the same risk factors that causes renal impairment. So it's a no-brainer. That's basically A lead to B. But what happens in those patients on warfarin versus those on rivaroxaban? Is there any difference in terms of renal deterioration of renal function, whether you are on warfarin or you are on NOAC? The answer is yes, and I will show you why. In patients with worsening renal impairment versus those stable, they benefit from NOAC over warfarin. So the reason that's in terms of the stroke risk. In terms of bleeding risk, there is no difference. So if you have a patient in atrial fibrillation, developed renal failure, worsening renal failure, they do benefit from NOAC over warfarin without increase in the bleeding risk. So this is what the study showed. And they concluded, and they now recommend in the guideline, that over time, NOAC, in particular dabigatran and rivaroxaban, may be associated with lower risk of adverse renal outcome than warfarin in patients with AF. Now, we should ask ourselves, why? If we go back to our basic knowledge in medicines, we know warfarin is a vitamin K inhibitor. So inhibits vitamin K. What is the function of vitamin K? Vitamin K helps to activate matrix GI protein non-carboxylated to change into carboxylated, and that inhibits vessel calcification. That's what the function of vitamin K in terms of the calcification. It inhibits vessel calcification. When you give those patients vitamin K inhibitors like warfarin, you increase the medial calcification. And that's what exactly also happens in patients with renal impairment. Patient with renal impairment also increases the medial calcification. So you have a renal impairment increase medial calcification, and you have warfarin increases the medial calcification. So both will increase risk of cardiovascular disease. And those patients develop renovascular disease and further deterioration in renal function. This is a study to link the renal outcome with the use of Xarelto versus warfarin, and you can see that in patients with more than 30% decline in eGFR, it favors Xarelto. Doubling of the creatinine, it favors Xarelto. And in the acute kidney injury, also favor Xarelto over warfarin. But with the end-stage renal failure, patient with dialysis, there is no difference between the two groups. And this is a nice illustration showing exactly what I said, and we believe that's all to do with the renovascular. So patient on warfarin, the calcification and the direct injury of the kidneys are probably the cause of further deterioration of kidney function. So in those patients with renal impairment, we favor NOAC over warfarin because of that. What other area in the atrial fibrillation? So those patients at higher risk of bleed, I just want to let you know that there are some other options. Watchman device is available. Watchman device is a little device you put into atrial appendage. 90% of the clot that goes to the brain, it forms inside the atrial appendage, get dislodged and goes up to the brain and causes stroke. And by closing this appendage with a Watchman device that can be inserted percutaneously, you reduce risk of stroke by almost 90%. It has an indication now, it has a PBS item number, for certain indication, those at high risk of bleeding. Catheter ablation, and they don't need to go through the whole slide, but those patients who are symptomatic consider catheter ablation if they fail medical therapy. So that can be also an option. You need to think about it early on before the atria get dilated. As I said before, the treatment of atrial fibrillation is a treatment of patient as a whole. And by treating their hypertension, diabetes, obesity is it's a major risk. And by losing weight and get an ideal BMI of less than 27%, you basically reduce risk of atrial fibrillation by almost 50%. Obstructive sleep apnea, alcohol, there's a lot of studies now and a lot of work done on alcohol, and they recommended zero alcohol to reduce risk of atrial fibrillation. So that's quite an interesting area in the field now. Dyslipidemia and other risk factors need to be managed. So it's a multidisciplinary team to manage atrial fibrillation. I'll skip this slide. I think it's an easy one to understand, and move into the last update on the guideline, which is they published recently and talked about in the recent European Society of Cardiology, is managing patients with atrial fibrillation after percutaneous coronary intervention for chronic and acute, in the chronic and acute setting. We all know when we insert a stent in a coronary artery, those patients need to be on dual antiplatelets, aspirin and clopidogrel, or any other antiplatelet like the ticagrelor and the prasugrel. Dual antiplatelets in patients with atrial fibrillation, you need to combine it with anticoagulation. If you combine it with anticoagulation, the risk of bleeding increases. So unfortunately, if you put them on aspirin, clopidogrel, and NOAC or warfarin, the risk of bleeding is high. At the same time, if you put them on two agents like clopidogrel and anticoagulation, risk of thrombosis is high. So we didn't have a guideline before this year. No guideline. It's up to the cardiologist to choose whether this patient can be on 3-agent or 2-agent. Now we have a guideline, finally, and hopefully will be my last slide. I think some of you get bored. Now this is, we have a guideline now. So patient with acute coronary syndrome, and I think this is a very important slide, and I think everyone will be interested. This is fresh, just been published. So patient with acute coronary syndrome, going for a PCI stent, patient with atrial fibrillation, they are on NOAC. You keep them on NOAC forever and forget about it. Do not stop it. Do not interrupt it. They will continue for life because the risk of stroke is high. What we need to talk about is the clopidogrel. How long you keep the clopidogrel for? Well, we prefer 12 months. But if there's a patient at high risk of bleeding, and we can see that dotted arrow, we can stop the clopidogrel at 6 months. What about the aspirin? We prefer give a 3 agents to start with. If the patient at risk of bleeding, we stop at 1 week. If the risk of bleeding is not very high, we stop at 1 month. And we keep the clopidogrel and NOAC for a year, and then we stop the clopidogrel. No aspirin, no clopidogrel, continue on NOAC forever. Now, for those without stent, you just go for medical management. Again, NOAC will continue forever. You give them a single antiplatelets, preferably clopidogrel, for 6 months, and then you either continue or stop. It depends on the bleeding risk. For those elective PCI, so that's elective PCI, once again, NOAC or warfarin continue for life. Do not interrupt, do not stop. If you're able to give clopidogrel for 1 year, do please. If you can't, stop at 6 months because of the bleeding risk. If the bleeding risk is even higher, you can stop even with 1 month. Aspirin, once again, either 1 week or 1 month. This is fresh, this is just published from the European Society of Cardiology, and that will be our practice from now on. This is the Hasbled, which I mentioned before. It's available. You can read it whenever. So oral anticoagulation should be initiated in a patient with non-valvular atrial fibrillation, and NOAC is any of these three agents I mentioned. It favors over warfarin. So unless you have a mechanical valve or you have severe aortic stenosis, NOAC is your first option. To minimize the risk of bleeding is the key issue. It's just like we talked about frailty, you manage frailty, you manage bleeding, but don't say, well, this is a patient, every time I give them NOAC, they bleed in the gut. Well, Dr. Ahmed Al-Rubai will manage that and will stop the bleeding. They need to be on anticoagulation. Dr. Ahmed Al-Rubai can do whatever and stop that bleeding from happening. And thank you very much. And I'm open for questions. And sorry about this long, I think, presentation. Was it about half an hour? I'm done. I'm open for questions, please. That was quite quick. So sorry about that. Any of these slides, as I said, I'm happy to make them available. And you can go through the slides. You can shoot me any emails if you don't have the time to ask the questions, but I'm happy to answer any question right now.
Sure. Thank you very much, Dr. Ali, for this fantastic presentation. One of the questions always come, do you stop at any age at all? Do you stop at 90, 85, or you continue giving the very elderly patients the NOAC as well? Any comment?
Yeah, so anticoagulation to continue. There is no indication to stop anticoagulation at any age if the patient's not really a high fall risk and the bleeding risk is acceptable. Again, the guideline, the European guidelines suggested, and in this year guideline, they suggested family meeting, family meeting, family meeting. Every time you need to sit down with the family, sit down with the patient, discuss the pros and cons. If the risk of the bleeding is very high, outweigh the risk of the benefit, you'll tell the patient, tell the family. If we stop it, you will have your risk of stroke is 7–10%. If we continue, your risk of bleeding is that. And as I said, you have the Hasbled calculator and you have the CHA2DS2-VASc calculator, and you give them the pros and cons and percentage, and you go for discussion. But if you have someone who's 90, he's in a nursing home, he works with a 4-frame aids, he needs full-time support, he's palliative, well, yeah, let it be. So I think it's all about discussion, but there is no age limits. Age is, it's become an old-fashioned factor. It's all depend on quality of life. You can see, you sometimes see an 80 or 95. I have a patient who's 95. He's still going to the swimming pool every day. So age is not a factor by itself.
Sure. And frequent episodes of bleeding, as you mentioned, for example, PR bleed, etc., do they count as more points toward high risk of bleeding in your equations, or not really?
Yeah, so the Hasbled, if you go to the Hasbled, it's got a multiple factors. So hypertension, abnormal liver and kidney function, stroke, bleeding, major bleeding. So major bleeding, it's either subdural or intracranial hemorrhage, or major bleeding as a bleeding in the gut. So it is considered as a major bleeding. So that you get 1 point out of this. You need to have more than 3 point or more to be considered as high risk. But if you have like a near-death event and bleeding in the gut and your hemoglobin is 5, that's a major bleeding. If you, Dr. Ahmed Al-Rubai, find the cause and treat the underlying cause, then yes, you can start on anticoagulation again. So treat the underlying cause. I have patients who had subedural hematoma, and I've spoken to the neurosurgeon and said, no, this is not a contraindication. We coiled it, it's fine, it's all good. He can go back on anticoagulation. But if the risk is very high, as I said, I mentioned a few other options. So you go for the occluder device, the Watchman device, put it there, and probably the chance of reducing risk of stroke is the same as the anticoagulation.
Oh, excellent. One of the situations happened every day that when we try to book elective people for operations, and we receive sometimes contradictory advice. Some of them would say, stop the NOAC for 2 days. Some of them would advise 3 days. Is it related to the magnitude of the intervention, for example, or they all should stop for 2 days full stop?
Yeah, so you're talking about major surgery or minor surgery?
Major surgery, say a laparotomy or an orthopedic intervention or something. Yeah.
Yeah. Do you see my slide?
Yeah, I can see. Yeah.
So that's basically slides gives you a summary of for how long you stop the anticoagulation for. For high risk, you stop it for 2 days. For low risk surgery, you stop it for 24 hours, unless you have a creatinine clearance, low creatinine clearance 15 to 29, you probably stop it for about 36 hours. Yeah. So it depends on what is your risk of bleeding, what is the risk of the surgery. High risk, 2 days, low risk, 1 day.
Yeah. The last question, Dr. Ali, that if you decide to operate urgently on patients who already had a Xarelto this afternoon, for example, coming for bowel obstruction. Yeah. So is there any emergency reversal agent to reverse the?
No, there is no emergency reversal agent for Xarelto or Eliquis. There is one for Pradaxa. So Pradaxa is the only NOAC that can be reversed. Now, that said, intensivists and some emergency physician, they use different agents to reverse the whole anticoagulation cascade. You can use that, but the result is not clear. So generally speaking, if you're able to wait for 24 hours, that's the preference. If you can't, take the patient to theater and take your chances.
Sure, excellent.
The only agent is for Pradaxa. There is the Pradaxa reversing agent that can reverse the anticoagulation in less than 10 minutes.
So one of the questions that, do you think that the Plavix in general is being overused on our patients? Some people on Plavix for years and years and years, and even the other clinician fail to specify exactly what was the original indication for this Plavix, especially if this patient is going for major intervention, for example.
Yeah, look, I think, look, I agree with you. There is a talk. I mean, it's not just a talk; it's a reality, which is a long-term stent stent restenosis, and we see that in the old generation stents, like the Cypher stent and the Texas stents. That's from early 2000s. We did have a late restenosis or late stent thrombosis. But we believe now it's not about the stents. The thickness of the struts of the stents, that was a reason. In the new generation stents is to do about the mechanics. So if the stent's not deployed well, there is in the long term, after you stop the clopidogrel, there is a chance of stent thrombosis. And because that's still playing in our mind, we keep the clopidogrel a bit longer than 12 months. So that's one reason. The second reason, there are some studies advocating for using the clopidogrel longer than 12 months, again, for the same reason, but mainly for complex lesion, bifurcation, left main, ostial left anterior descending artery. We tend to use clopidogrel a bit longer than what's recommended for 12 months. The other reason, and Ahmed Rubai knows that, is those patients who bleed on aspirin. We give them a clopidogrel instead. Patient who gets stroke on aspirin, we give them Plavix instead, not combined, because there's no benefit from combining aspirin and Plavix in patients with recurrent stroke. We give them Plavix by itself instead of aspirin. But if you use the Plavix for 3 years, 4 years in combination with aspirin after PCI, I totally agree with you. It's not indicated. You don't need to use it more than 12 months. In some studies, maybe up to 24 months, and that's it. You need to stop it.
Thank you very, very much, Dr. Ali. That was very comprehensive and refreshing on AF and anticoagulants. I can see no more questions from the participants. And if
Is that because they sleep or because they
No,
bored?
no, no.
They don't want to.
No,
because they are stunned, I think.
حقيقة excellent.
No worries. It's my pleasure.
Excellent. That was very useful because we see those questions are being sort of asked every day in our practices, etc. So that was a good refreshment tonight. If there's no more questions, I would like to thank our lecturers, Dr. Al Fayyad, Dr. Mohammed Al Mukhtar, for this awesome evening, awesome presentations. And I thank all the participants for the time. I think it was a good start. That is our first webinar. It has been all recorded and still recording. And I am very keen actually for perhaps a webinar every month, which we will try to push forward. So this year, although we hated it in the beginning, but it hasn't finished yet. Still 2 months to go. So we need to achieve hopefully 2 more webinars before the Christmas day. And we'll be looking forward to that. Thank you once again to everyone that participated tonight. And if no more comments or questions, I wish a very good night to all of you.
Thank you. Thanks all.
مع السلامة. صباحاً على خير.
صباحاً على
Thank you
خير.
very much. شكرا
شكراً.
جزيلا. مع السلامة. صباحاً على خير.
شكرا.
Thank you very much. Take care.
مرحبا.
Have a
أهلاً.
lovely weekend. We have a long weekend here in Melbourne.
ليش؟
واو. لاكي.
This is
خاصة إن
unfair.
شالت الريستريكشن راح تتونسون ها.
لا تزيد الحالات.
هسه تتونسون راح تنشال الريستريكشن.
إن شاء الله إن شاء الله.
إن شاء الله يلا ندعي لكم بالسلامة جماعة ملبون.
تزيد الحالات تزيد.
وين
الله
تزيد؟
بالتوفيق.
ماكو حالات.
لا اكو مدرسة سدوها.
لا والله.
دكتور
هي مدرسة عربية دائما عربية.
بطل الريكوردينج، وقف الريكوردينج، راح نصير نحكي بالسياسة هسه.
تخوف.